Hi, Dr. Gersh. Good morning. I'm Brian. I'm one of the cardiology fellows here. I'll be introducing you this morning. Can you hear me okay?
Yes, I can. Can you guys hear me, or do you need more volume?
The volume sounds great on my end.
Okay.
All right, guys. So it is 7:30, so I'm going to get started here. Good morning, everyone. It's 7:30, so we'll get started. My name is Brian Mitchell. I'm one of the second-year cardiology fellows here, and I would like to welcome you to our Cardiology Grand Rounds lecture today at the Poly Heart Center. I have the honor of introducing our distinguished guest speaker and visiting Congin lecturer, Dr. Bernard Gersh. And just to give you a little more information about the Congdon lectureship, in 2010, Natalie and Jack Congdon established the Natalie and Jack Congdon Visiting Scholar in Cardiology, which enables the VCU Health Poly Heart Center to attract a number of talented cardiologists. John, or Jack Rhodes Congdon Sr., was a student of the Augusta Military Academy and a graduate of Thomas Jefferson High School, where he was first captain of the Corps Cadets. He later served in the United States Army as a military policeman stationed in San Antonio, Texas. After his service in the Army, Jack helped to build the family trucking business of Old Dominion Freight Line and Old Dominion Truck Leasing Incorporated. Jack was a proud supporter of the Massey Cancer Center and Poly Heart Center, and he passed away on October 13, 2013. Jack's wife of 57 years, Natalie Congdon, graduated from Thomas Jefferson High School as well, where she was a sponsor of the Cadet Corps and Queen of the Junior Senior, and attended Hollins College. Natalie passed away on January 6, 2010. Jack and Natalie have 3 children, Susan, John, and Jeff, 8 grandchildren, and 5 great-grandchildren. We're grateful to Jack and Natalie for establishing this visiting scholar program and thank their family who continue to be avid supporters of the Poly Heart Center. Our speaker today is Dr. Gersh. Dr. Gersh is a professor of medicine in the Division of Cardiovascular Diseases at the Mayo Clinic in Rochester, Minnesota. Dr. Gersh completed his clinical training at the University of Cape Town in South Africa, followed by a PhD at the University of Oxford, Trinity College in Oxford, England, where he was a Rhodes Scholar. Dr. Gersh was previously the W. Proctor Harvey Teaching Professor of Cardiology and Chief of the Division of Cardiology at Georgetown University Medical Center. Dr. Gersh has over 45 years of experience in cardiovascular disease research with over 1,100 publications, including 146 book chapters. Dr. Gersh is the recipient of 32 invited professorships nationally and internationally, of numerous awards, which too numerous to list here, for his excellence as both a teacher and a researcher. Dr. Gersh has served as an editorial board member for many journals, not least of which is Circulation, and has been named one of the best doctors in America. Now, Dr. Gersh's research experience is vast, so I couldn't just hone in on one thing, but it includes topics ranging from acute and chronic CAD to sudden cardiac death. But in particular, he has spent over 30 years studying the epidemiology and outcomes of atrial fibrillation. His focus on the epidemiology, pathophysiology, and outcomes of atrial fibrillation have contributed greatly to our understanding of that disease and have influenced current guidelines. So we're grateful for Dr. Gersh's experience on this topic and look forward to hearing from him. Just to mention, at the end of the lecture, we're going to leave time for questions, so that we ask you to submit questions via the chat Zoom function below as they arise during the talk, and then I'll get to them at the end. We're pleased to offer CME credit for our Grand Round Conference Series. To claim credit for today's session, text the code shown at the beginning and the end of the presentation to 804-625-4041. For any questions or to log on to your CMA account or your cloud CMA account, visit vcu.cloud.com. And without further ado, I'll pass it over to you, Dr. Gersh.
Thank you very much for the invitation. It's really a pleasure. I apologize for my croaky voice, but I'm speaking from South Africa. It took me 36 hours to fly out here. So I've spent quite a lot of time in an aircraft cabin in the dry air, so I'm a bit croaky. So I'm going to talk about the indications for coronary revascularization and the preferred method or methods of coronary revascularization in chronic coronary syndromes, reconciling the results of the randomized trials. Now, I want to emphasize chronic coronary syndromes for one good reason. This article by Dr. Colin Berry from the UK really made a case for consolidating the nomenclature, and pointed out that the terminology is really varied from chronic stable angina in 2002, stable ischemic heart disease, 2012, stable coronary disease, ESC guidelines, 2013. And then in 2019, and I served on this writing committee of the European Society of Cardiology, after much debate, we decided that probably the best term is chronic coronary syndromes, and the reason being that chronic stable angina is really stable until it becomes unstable. And event rates are actually very high, particularly in patients with, quote, stable angina who've had a prior myocardial infarction, where there really is a very high event rate. To put the trials in perspective, we need to step back in time a little bit. And what I want to show you here are the results of clinical trials for mild to moderate chronic stable angina, because that's the terminology that was used at the time of these trials. And these are the trials that by and large showed a complete lack of benefit in death or MI. And I do want to emphasize, I am talking about chronic stable syndromes or chronic syndromes. For acute coronary syndromes, revascularization has had a dramatic impact upon outcomes. But in chronic disease, it's more problematic. Now, the very early trials were those of bypass surgery versus medical therapy. And I might add, these trials are now over 30 years old. And medical therapy 30 years ago was basically just not having surgery. Now, these trials showed a lack of benefit in death or MI, except in sicker patients, defined by severe angina, multivessel disease, European coronary surgery study, multivessel disease with LV dysfunction, the CAS trial from the United States, and then the VA trial in, I think, 1978 of left main coronary disease, which established the benefit for surgery. And interestingly enough, this trial only had, I think, 113 patients. Trials of PTCA versus medical therapy, no benefit. PCI, stenting versus medical therapy, no benefit in terms of death and MI. And there are 5 exceptions, and I want to begin with the most recent of these trials, the FAME2 trial based upon an FFR of less than 0.8. And here the major benefit of PCI was on urgent revascularization. And then at 5 years, there was a reduction in myocardial infarction. No benefit in mortality, but the trial wasn't powered to answer that. These other trials, 4 trials, all did show some benefit for bypass surgery. I'm not going to go into any detail because they were really not, the patients included in these trials were a little atypical in that they did not all have chronic stable coronary disease. They had a variety of other syndromes. But basically, no benefit in death or MI except in sicker patients. We've had several meta-analyses. They all show the same, with the exception of one that showed a benefit for PCI. We don't need any more meta-analyses. And I like this quote from a Nobel laureate, an economist from the UK: if you torture the data sufficiently, sooner or later it will confess. We have the data. And although the data have their limitations, and many of the data are old, the bottom line is that there is no benefit on death and MI with coronary revascularization in chronic stable or chronic coronary syndromes, with the exception of the sicker group of patients that I've mentioned. So this led to the guideline recommendations. These are from the ESC, and I show these because they're the most recent, 2019, very similar to AHA, ACC, but just these are more recent. And class 1 indications for coronary revascularization for survival or to improve prognosis are really based upon anatomical subsets defined in these older trials: left main disease, proximal LAD disease, 2 to 3 vessel disease with impaired LV function. This was the CAS trial of early 1980. Large area of ischemia detected by functional testing, namely 10% of or greater of the LV, or an abnormal invasive FFR. I want to come back to that. And then what is logical, a single remaining, there should be patent coronary artery with stenosis greater than 50%, level of evidence C because we don't have any trials, but it's logical. If you've only got one vessel supplying coronary circulation, one patent vessel, and that's diseased, it makes sense to revascularize. For symptoms, I think everybody is in agreement that in patients who have not responded to medical therapy, who have an impaired quality of life, there is a real benefit to revascularization. And I might add that the guidelines are really based primarily on evidence gained from older trials of bypass surgery versus medical therapy. And in the next slide, I'll show you the data from the more recent trials of PCI. And I want to come back to this because this is really the focus of the Ischemia trial. Now, the three most recent trials of PCI versus or revascularization versus medical therapy are Courage, Barry, 2D, and FAME2. And these are the conclusions. In angiographically selected patients with chronic stable angina and preserved LV function, there is no benefit from coronary revascularization upon death and MI. Now, of these three recent trials, here were the exceptions. In the Barry 2D trial of diabetics, we defined an angiographic and clinical subgroup considered at much higher risk. And there was a benefit for bypass surgery in that subgroup, not PCI, but bypass surgery. The FAME2 trial and FFR of less than 0.8, there was a benefit of PCI, mainly upon repeat revascularization, but at 5 years, there was a benefit in terms of a lower rate of myocardial infarction. And subsequently, a meta-analysis of FAME2 plus 2 other trials demonstrated the same outcomes, a benefit. So the question that remained really is how to extrapolate to the population at large and the role of stress testing. And what is the role of revascularization in patients with moderate to severe ischemia and mild to moderate angina? And that brings us to the Ischemia trial. Now, one of the driving factors or rationale for the Ischemia trial was this very large registry study from Cedars-Sinai Medical Center of almost 14,000 patients with adenosine or exercise SPECT. Shown here is the proportion of the total myocardium that was ischemic, and here is the log hazard ratio for mortality. And what you see is when about 12.5 to 15% of the myocardium is ischemic, the hazard ratio goes up with medical therapy and relatively down with revascularization. And at this point, there's a crossover where revascularization improves survival compared to medical therapy. And this is an important study that provided much of the rationale for the Ischemia trial. The trial presented in November at AHA last year, published in New England Journal earlier this year. This was the composite outcome. I beg your pardon. Let me just go back. Quite a complex composite outcome, including resuscitated cardiac arrest, hospitalization for heart failure, unstable angina, and CV mortality. Large trial, very difficult to do, and Dr. Judy Hoffman did an amazing job bringing this trial to fruition. Over 5,000 patients, and overall a neutral trial, hazard ratio 0.93, p-value not significant. At 6 months, however, if you look at the invasive arm in red, there is a higher event rate in the invasive arm, a difference primarily due to a higher rate of myocardial infarction, and these were peri-procedural myocardial infarctions. When you get out here, at 5 years, however, the curves have crossed over, and there's now a higher event rate in the conservative arm, and that is due primarily to spontaneous myocardial infarctions, which we feel have a greater impact on outcomes than peri-procedural MI. Be that as it may, the trial at 5 years, there's no significant difference, but this trend is real, and hopefully there will be funding to do a long-term follow-up at 10 years but we do not know yet. At this point in time, relatively few people were being followed, only about 500, but hopefully we will get ultimately another couple of years of follow-up, which is important. This is a sub-study that I think is equally important, or certainly important, from Dr. John Spertus, which is the effect of treatment on outcome and quality of life in terms of based upon baseline angina frequency. Now, that was calculated using the Seattle Angina Questionnaire frequency score. 0 to 35 means daily angina, 35 to 65, weekly angina, 65 to 95, monthly angina, and greater than 95, no angina. And this is at month 3. And shown on this axis is the effect of the invasive arm on the conservative versus the conservative arm stratified by angina frequency. And what you can see is that in patients who have a Seattle angina score of 35, which corresponds to daily angina, there is a 15-point reduction in the angina frequency score with the invasive versus the conservative arm. And that converts someone from daily angina to weekly or almost monthly angina, a profound effect on quality of life. But on the other hand, if you had relatively unusual angina to begin with, or infrequent angina, monthly, let's put here angina score of 85, then the benefit on the angina score is very minor. So really what the point that this made is in people who are significantly symptomatic, there is a substantial and impressive benefit from the invasive arm on outcomes. And this was the same at 12 months and 36 months. So what are the implications of the ischemia trial? I think we really need to understand who is in this trial. Recent ACS excluded, LV ejection fraction less than 35% excluded. Left main disease, 5% of people. I need to emphasize that in the ischemia trial, the screening criteria were the presence of ischemia on a stress test, but all of these patients underwent a blinded coronary CTA to exclude left main disease or non-obstructive disease before they were enrolled. So left main disease was excluded, and then people who were severely symptomatic on optimal medical therapy were never in this trial. And then there's this category of patients, high likelihood, quote unquote, of unprotected left main disease according to the judgment of the physician. We don't really know who these patients are, but it appears that these were people who on a stress test, according to the judgment of the physician, were thought to be high risk. Patients with LV dilatation, drop in blood pressure, very short duration of exercise. Dyspnea is a presenting symptom. We don't really know the details of these patients, and I'm not sure we ever will, but they were excluded, and that I think is important. So the patients were stable, low risk of mortality, 92% angina class 1 to 2, median ejection fraction 60%. The outcomes were favorable in growth in both groups. And this is really confirmatory of prior trials, which basically showed low mortality. A trend towards an increasing rate of late spontaneous MI in the conservative group. Is this the benefit of revascularization? Or could it be that revascularized patients had a longer duration of dual antiplatelet therapy? We don't know that. And we need longer term follow-up. I think a very impressive improvement in the quality of life in patients with significant symptoms to begin with, but not in those who only mildly symptomatic. Makes sense. And this is from an accompanying editorial by Antman and Braunwald, who said an invasive strategy is a reasonable approach at any time for symptom relief. If you start to decide you're going to treat someone with optimal medical therapy to begin with, you don't have to carry on that trial for a year. You can make a decision in a month or 2 or 3 where the medical therapy is working. And if it's not, then revascularize. I think we're going to see a likely decline in the future use of stress testing versus CTA and FFR. And this is actually in the ESC 2019 guidelines. And the reason is, in this study, as I mentioned before, 5% of patients who had left main disease that was not suspected, and on CTA, 14% of patients had no obstructive disease. And I think we will at least, there'll still be a role for stress testing, but I think we're going to see far more use of CTA, and that is in the 2019 guidelines. The importance of a normal ejection fraction is illustrated in this sub-study by Renato Lopez from Duke. 7.7% of patients in the Ischemia trial had either heart failure or an ejection fraction of less than 45% without heart failure. And if you look here at the group who had heart failure and LV dysfunction, conservative arm in yellow and orange, the invasive arm, there is a significant benefit to the invasive arm in terms of the composite endpoint. And this is something that we learned almost 30 years ago in the CAS trial. Patients with LV dysfunction are at high risk. And if you look at those who did not have heart failure, you see the solid lines, no difference in the invasive versus the conservative arm. And the other feature of this trial was when stratified by ejection fraction, the cutoff was around about 50%. Below that, you can see that the survival, this is primary endpoint, all-cause mortality, CV mortality, the survival or mortality is lower in the invasive arm than it is with the conservative arm. Well, this is interesting data that has really just been published, but at the time I made the slide, it had only been presented. This is survival according to the number of diseased vessels, not just survival, the composite event rate, in the conservative and the interventional arm. And what it tells you is, again, what we knew for a long time. The more vessels diseased, the worse you do. And yellow is single vessel, green is 3 vessel disease. But this was a surprise, because remember, this trial was based upon the ischemia as one of the major inclusion criteria. And what you see here is the more severe the degree of ischemia, the lower the event rate. This is not statistically significant, but it's there. And then with the intervention arm, the same thing. In green, the more severe the degree of ischemia, the lower the event rate. And this is difficult to understand. And again, of course, there was no significant difference between the two groups, invasive and conservative. Subsequently, about 2 weeks ago, this has been published in Circulation. And what you see here is all-cause mortality stratified, all-cause mortality in patients with severe ischemia, and myocardial infarction rates in patients with severe ischemia, conservative versus invasive, no difference. But if one uses the Duke score, which is an anatomic score of the extent of disease with a 3-vessel proximal LAD and 2-vessel, now what you see is no difference in mortality, but a significant difference in myocardial infarction, and the 4-year rate of combined cardiovascular death and MI was lower in the invasive strategy. I think an important outcome, and an important observation. But what one doesn't really understand is why the lack of the impact of the severity of ischemia upon outcomes. And this is recently discussed by myself and Dr. Deepak Bhatt in the European Heart Journal in a commentary on the ischemia trial. Well, maybe ischemia is one of many factors that may impact prognosis. Selection bias in regard to trial enrollment, that perhaps those patients with the most severe degrees of ischemia were excluded. They used 4 different imaging modalities to quantify ischemia, which introduces heterogeneity and may dilute the impact. And then I think there's this factor, ischemia or the extent of anatomic coronary disease is a marker of a greater, this should not be mere, a greater atherosclerotic burden. And The majority of plaques, though, are non-obstructive but vulnerable. And perhaps they do cause ischemia of the microvasculature, but maybe revascularization will not benefit those patients. We just don't know that. The impact of revascularization versus medical therapy. And it really depends on whether the ischemia is related to a fixed stenosis or whether it is due to more diffuse but non-obstructive disease. The fact remains that contrary to our expectations, the severity of ischemia was not a determinant of an improved outcome with revascularization or the event rate in both groups. So perhaps we need to rethink a bit. And I think we maybe are moving into the era of plaque characterization and vulnerability as new targets. And what is the role of the microvasculature, which I think is crucially important to outcomes as we, and the pathophysiology of coronary disease, as we try to make the case for this in a Circulation Review 2018. But perhaps we are moving away from some of our time-honored and standard concepts, which may not hold true. And I want to just show two slides to emphasize this. Study from Tiketi from the Brigham, 300-odd patients undergoing stress testing who had PET imaging for myocardial blood flow, and they looked at the impact of coronary flow reserve on outcome, CV death and heart failure. If coronary flow reserve was high, and this is telling you, coronary flow reserve tells you about the entire coronary tree, not just the epicardial related vessel, but also the microvasculature. And if coronary flow reserve was high, there was no significant difference between no revascularization in yellow, PCI, or bypass surgery. Obviously, if there were more patients, I think we would see a benefit for PCI and CABG. But if coronary flow reserve was low, now you see not just a significant difference in favor of revascularization, but bypass surgery far better than PCI in this group with low coronary flow reserve. So it's an important study that makes us rethink some concepts, I think. And then more recently, Greg Stone published this, I think, very important hypothesis generating study on patients who underwent revascularization post-MI, but also had non-culprit lesion plaques that were not revascularized. And they were stratified according to high and low risk based upon plaque burden and the lipid content of the plaque. And if you were considered at high risk, this is the event rate, and low risk, this is the event rate, which is almost a third of those who were at high risk. And I think, hopefully, we will see some form of prospective large-scale trial on revascularization for non-culprit plaques in the near future. So if we go back to the ESC guidelines, what may have changed? And I think this is what has changed. A large area of ischemia detected by functional testing, greater than 10% of the LV or an abnormal invasive FFR. And I think now the question is, we've learned from the ischemia trial, it's a good trial. Is it ischemia alone, or is it ischemia in combination with other high-risk features? So if you have a patient with severe ischemia and they drop their blood pressure with exercise, they can only exercise for 2 to 3 minutes. Dyspnea is the presenting symptom. Those patients with ischemia, I think, would benefit from revascularization, but ischemia alone, we've learned something from this trial, is not a determinant of outcome. So in this paper in the European Heart Journal from Deepak Bhatt and myself, these are what we summarized as the implications. The indications for angiography and revascularization, I think if you have severe symptoms, to improve the quality of life. If you have severe ischemia on imaging, plus other high-risk stress test features, it's reasonable to assume that you could improve survival. Severe ischemia alone, I think this is where one needs to consider trial of optimal medical therapy, and this is the lesson from the ischemia trial. LV dysfunction remains, as always, an important criterion to consider revascularization. If you see a patient who has already undergone angiography, we have the prior anatomic-based guidelines to drive our decision-making. They're not perfect, they're from old trials, but they're pretty logical and reasonable. And now I think we are learning so much more about hemodynamic lesion assessment with FFR or IFR. The ischemia trial is an important trial. This is a study from Australia, from primary care practices, 207 practices, patients with stable angina, and what proportion had more than one episode a week? Probably this was 50%. The minority of patients in this study had greater than one episode a week. The majority were having monthly angina, less frequent angina, and the ischemia trial applies to many of them. And this is from the ACC NCDR registry, the appropriate use criteria ratings. So for these appropriate use criteria, ACC said it is really appropriate to perform percutaneous coronary intervention in patients who are asymptomatic or have non-anginal chest pain. Well, that's pretty understandable. And particularly if they have no LV dysfunction. So shown here in yellow are the current appropriate use criteria. And in orange, how would they be modified if we took the ischemia trial into consideration? And if you go to the right of this slide, really appropriate, what you see is that right now, only about 3% of these 352,000 patients with stable disease, about 3% were inappropriate. If we then took the modified criteria using the ischemia trial, where ischemia alone is not a criterion, this would now go up to 22% considered really appropriate. That's another 50,000 patients. And that is, from a cost standpoint, a huge factor. Now let's move away from the indications to trials of methods of revascularization, PCI or bypass surgery. Cabbage versus PTCA, 15 trials. The only difference, there was no difference in death or MI except in diabetics. Bare metal stents versus PTCA, no difference. Bare metal versus drug-eluting stents, no difference. 5 trials of bypass surgery versus bare metal stents. And again, the only benefit for bypass surgery over PCI on death and MI was in the diabetic subgroup. And then we have 3 trials of bypass surgery versus drug-eluting stents, 2,700 patients. And again, in sicker patients with 3-vessel left main disease, high and intermediate syntax scores, and again, diabetics with 3-vessel disease, there was a benefit from bypass surgery. So we can summarize that these trials showed no difference in death or MI, with the exception of diabetics and sicker patients with more extensive disease, which favored better outcomes with bypass surgery. Now, we need to understand the limitations of trials and registry studies. Registry studies have selection bias, and they're all confounded, one degree or another. Multivariate analyses help, but they do not eliminate confounders. But they're more relevant to practice at large. But randomized trials have their own bias. And this is a paper written with one of our surgeons. And let me just, come back here. But randomized trials have their own bias. And what we called in this review, we called it entry bias. Because remember, to go into a randomized trial, the inclusion criteria mandate clinical equipoise and eligibility for both forms of therapy. So when you take trials of PCI versus bypass surgery, These are good surgical candidates, and they are good PCI candidates. If they're not, then you have no ethical right to randomize that patient. So that is a bias. It's not a pejorative bias. It's a fact of life that is not often appreciated, where people say, oh, the Courage trial. Oh, yeah, only 10% of people that were enrolled, that were screened, were enrolled. And that's because in the other 90%, you probably had a preference that they would do better with one form of therapy over another. The other problem is these trials take a long time to do. So by the time they completed, they run the risk of obsolescence. There's a better stent, a new antithrombotic, and other factors. And this is from an editorial I wrote with my colleague and friend, Dr. Bob Fry, about the New York State Registry in 2005. And we said, things may not be as they seem. You've got to look at registry studies critically and randomized trials critically. It's composite endpoints. They have their advantages. I mean, if you use a composite endpoint, it improves statistical power, and you have a higher event rate, which improves, again, your ability to show a difference. They're convenient. They mean you can reduce sample size and costs. But there's a caveat, and when you use composite endpoints, you can oversimplify things by putting too much emphasis on the composite. And I want to give you an example of that. The Syntax trial of bypass surgery versus drug-eluting taxus stents. This was the composite endpoint, 12.1% with bypass, 17.8% with drug-eluting stents, p.002. But let's just look carefully at the components of the composite. Death, no difference. MI, no difference. And the only difference in stroke was in stroke, 2.2% with bypass surgery, 0.6% with drug-eluting stents. And if you look at repeat revascularization, that's what drove the composite endpoint. So it's important really to always list the components of the composite endpoint. And just because you have a higher MACE rate doesn't mean that you had a higher or a difference in mortality. And I think it's an important consideration. And this is taken from near where I live in Jackson Hole. Going beyond this point may result in death and or loss of skiing privileges. Now, I don't think at $180 a day for a lift ticket, losing your lift ticket is serious, but it's not quite commensurate with death. 5-year mortality with and without diabetes. 11,000 patients over 11 randomized trials, 73% with drug-eluting stents. Very important point. Without diabetes, no difference between PCI and CABG. With diabetes, there's a huge difference in favor of CABG. And I think we can understand that. Diabetes is a diffuse progressive disease, chronic total occlusions, increased plaque vulnerability. And these patients need complete revascularization. PCI is directed to a lesion or maybe lesions, but it doesn't address the future culprits lining the vessel wall, the non-obstructive vulnerable plaques. Whereas bypass surgery bypasses the entire epicardial vessel, and this is where the importance also of aggressive secondary prevention, which I think has really had a huge impact on the results of revascularization as well as medical therapy, and then microvascular dysfunction. Now, if you look at the Syntax trial, what you see here is PCI versus CABG. Everything to the right is a higher event rate with PCI. And this is the Syntax score shown here. And you can see that in intermediate and high Syntax scores, there's clearly a benefit for bypass surgery. But with left main disease, you see something different. In fact, the benefit was only in those with a high Syntax score. Those with a low and an intermediate Syntax score fared much the same. And I want to just drop that slide and then move on to then point out that the EXCEL trial, that led to the EXCEL trial run by Greg Stone, where in fact, the Syntax trial, although it was a dated trial, suggested that there may be a role for PCI in patients with left main disease. A third of the patients in this trial actually had a high syntax score. If you look at death, stroke, or MI, no difference. But if you blow it up, what you see early on, a high event rate due to periprocedural stroke and MI against surgery, and then the curves come together. And at 3 years, we predicted that we would probably see the curves cross over. And if you look from death from any cause, not statistically significant, but again, a benefit in favor of surgery in orange. The Nobel trial from the Scandinavian countries showed a much higher MACE rate with PCI, but no difference in mortality, and stroke rate inexplicably high after 1 year in the PCI arm. Cannot explain that, but basically no difference in mortality. So the clinical implications, and this is from Greg Stone, Deepak Bhatt, and myself, Circulation, 2007. We said, you know, these two trials may change the guidelines by broadening the patient pool that might undergo PCI. And really what it is in the end, the trials have shown us PCI is feasible, it may be effective, and really what you have to do is use your common sense. And it's the decision is not based upon a p-value that may or may not reach significance in a trial. It's based upon life expectancy, comorbidities, and other technical factors, and patient preference. That took us to the 5-year data published by Greg Stone. And now what you see, death, stroke, or MI, the curves have crossed over, but p-value 0.13. And the real difference is a higher rate of repeat revascularization, which we knew from other trials. And then if one looked at cardiovascular death from any cause, there is now a significant difference in favor of bypass surgery. This, I might add, was one of about 30 pre-specified secondary endpoints. And rates of adjudicated definite cardiovascular deaths were similar. The major difference in all-cause mortality was driven by non-cardiovascular deaths, especially from cancer and infections. Stroke rates higher with surgery, but again, not statistically significant. And then a meta-analysis of 5 trials of drug-eluting stents versus bypass surgery. I just want to emphasize one thing here. This is the overall mortality, 1.03 relative risk, not statistically significant. Cardiovascular death, 1.03, also not statistically significant. And the only outlier actually was the EXCEL trial for all-cause death, where there was a significant difference in favor of bypass surgery. That then led to the controversy, which just erupted in 2019, still continues. European Society of Cardiothoracic Surgery, leading cardiothoracic surgeon questions EXCEL trial's conclusion. Surgeon David Taggart, who was actually chairman of the surgical committee in this trial, in the EXCEL trial, he set the meeting ablaze when he accused EXCEL researchers of stacking the deck in PCI's favor. The European Society pulls out of the left main guidelines after an interview on a BBC, British Broadcasting Corporation, alleging an EXCEL trial cover-up. EXCEL investigators, we actually published a rebuttal written by Dr. Stone, countersigned by 15 of us, but the debate continued. And finally, this comment is the tide turning on the grubby affair of EXCEL and the European guidelines, which I think is a bit tough. And really, what is happening right now is the guidelines are being revisited. There's a white paper coming out from ACC, AHA that I'm involved with, which I think is going to be a very measured and balanced statement. And we have someone from the ESC guidelines part of this. You know, one really has to ask, is this a controversy or is it a distraction? Is it really a controversy? And I think that when you really look at it from a distance, it's whether you accept CV mortality or total mortality as the endpoint. And that's up to you. The trial endpoint predetermined was CV mortality, and total was a secondary endpoint. And the other is on what definition of MI, whether you use the predetermined definition, which was CPK-MB, to define, and then whether you define or whether you categorize MIs as spontaneous or peri-procedural, or whether you use the third universal definition based upon troponins, that can affect the outcomes of this trial. And that is really, I think, the gist of the controversy. Any loss of myocardium is undesirable, but what is clinically important, it's not whether you have a peri-procedural CPK rise or troponin rise. It's whether that is associated with increased mortality, heart failure, or arrhythmias. And it's very difficult to define procedural MI. The argument has gone on for 30 years. What biomarker, CPK, troponin? What threshold? Do you need ECG or angiographic supporting data? Should the criteria for a peri-procedural MI be the same for bypass surgery or PCI as it was initially in the EXCEL trial? And many biomarker elevations may be an epiphenomenon, and there are multiple confounders. To try and conclude, I think the absolute magnitude of the difference in hard endpoints is small in the EXCEL and other trials, but favor bypass surgery. There is clearly a role for PCI in selected patients with unprotected left main disease. And the considerations are those I mentioned before: clinical judgment, coronary anatomy, patient-related factors, including preference. And this is something that we don't emphasize enough in trials: operator proficiency. Not all surgeons are equally skilled at, say, bilateral mammary grafts. Not all interventionists are equally skilled with left main interventions. So if you look at the recommendations now for the European Society, left main disease, low syntax score, class 1 for both bypass surgery and PCI. Left main disease with an intermediate syntax score, right now, this is a 2A, and with a high syntax score, it's a class 3. The only thing that could change is this class 1 recommendation. Maybe it'll go from a 1 to a 2A for PCI. Is this going to change my practice? No, because we already in practice do this, and we make a clinical judgment. It's not just based upon a definition of peri-procedural MI or a small p-value. So the Shakespeare play, Much Ado About Nothing, it's not about nothing. I think these are issues raised which warrant discussion and have been addressed, but I really believe that the controversy is overblown, and what we will come out with is a statement that is very balanced, that it accepts that in complex disease there's a benefit to surgery, but basically in the end it is a clinical decision based upon multiple factors. So I want to summarize in conclusion 3 decades of randomized trials in stable coronary disease. And what have they taught us? Revascularization for prognosis. The early trials of bypass surgery and medical therapy taught us that there is a benefit to revascularization. And in terms of PCI, in a high-risk subgroup with diabetes, there is a benefit to revascularization. PCI versus medical therapy, FAME2 trial, major benefit on urgent revascularization and 5-year rate of MI. And then in terms of whether bypass surgery is superior to PCI, in the diabetic subgroup undergoing PTCA and Barry, benefit for surgery, Barry 2D in diabetics, benefit for surgery, syntax 3-vessel and left main disease with high and intermediate syntax scores, benefit for surgery, and 3-vessel disease in freedom. The sicker the patient, the greater the benefit of revascularization versus optimal medical therapy and bypass surgery versus PCI. And finally, we need to understand the limitations. We now have better stents, better pharmacotherapy, more judicious use of PCI. Will plaque characterization change our way of looking at the indications for revascularization and how to revascularize? The syntax 2 score, the residual syntax score, which is a very good way of looking at the completeness of revascularization. IVUS, OCT were not part of these trials. Radial artery approach to PCI, multiple arterial bypass grafting, not part of these trials. Shared decision-making. And then what about this? The newer medical therapies, PSK9 inhibitors, SGLT2 inhibitors, GLP-1 agonists, low-dose rivaroxaban, and the Compass trial. All of this, none of these medical therapies were in these trials. And then the role of the microvasculature, which I believe is going to dominate many of our investigative efforts in the next 10 years. So my final slide is a word of caution. From my colleague, Rajiv Gulati, 1991 to 1996, if you looked at 5-year mortality after PCI at the Mayo Clinic, and this was published in Circulation, cardiac mortality drove 5-year mortality. 1997 to 2002, our patients are older and sicker, and we're better at PCI. And now 5-year mortality is equally distributed. From 2003 to 2008, what dominated late mortality was non-cardiac mortality in orange, which really tells us that it's not just how we revascularize, but we really have to pay attention to the entire patient, not just in terms of secondary prevention, but treating the comorbidities in these older and sicker patients, which really also has an impact on our decision-making in terms of whether revascularization will improve overall prognosis or mortality in sicker patients. So thank you for inviting me, and thank you for your attention. Dr.
Gersh, thank you for a wonderful lecture. That was wonderful. We have a couple questions. Have 2 questions from Dr. Antonio Abate. Just pulling up my chat here, excuse me. For some reason, my chat has gone blank. Could someone repost the questions that were there for me real quick? But the first question for from Dr. Abate was that it seems like some of these studies have been in populations outside of the U.S. And I believe his question was essentially, thank you, whoever posted that. Most of the patients were outside of the U.S. And he was asking, are we confident that the treatment techniques in terms of stress testing, some without imaging, and PCI stent technology is consistent with U.S. population?
Yeah, it's a very good question, and we've run into trouble with that before. I think that the Ischemia trial was primarily in the U.S., but even within the U.S., there were 4 different methods of stress testing looking at ischemia. So, and one of the questions that I was raised here in South Africa earlier today was, well, what about if all we have is a treadmill? What's the role of treadmill exercise testing as opposed to PET scanning? So I think it is very relevant. The ischemia trial, by and large, was a US trial, but where we learned the lesson about geography, and we have to be very cognizant of this, was the TopCat trial of spironolactone in patients with HFpEF. And I served in the Data Safety Monitoring Board of that trial, and we subsequently published a paper with Dr. Michael Bristow discussing the lessons we learned from that trial. What we found very early on in that trial, patients from Russia and Georgia looked different. They had more angina, they were younger, they were enrolling at an incredibly rapid rate. And we said to the sponsors, the NHLBI, there's something funny about these patients, and they're different. And in the end, what happened, and this was published in Circulation, that the TopCat trial of aldactone was a neutral trial, but in anybody outside Russia and Georgia, it was a positive trial. Now, it's dangerous to do these subset analyses, but it was powerful enough that, in fact, the subset analysis came out in Circulation. So I think the lesson is this. I don't want to pass any judgment on exactly what happened there, but they were different. We also subsequently found out many of them were not taking their drugs. Their changes in serum potassium were less, and so on. So I think there's a warning there. And anytime you do a trial, and it's a multinational trial, I think you have to be very careful when one national subgroup starts to dominate. You can get into trouble. But I do believe that ischemia is generalizable by and large. But it may not be generalizable to every single place in the US, but that's any trial. It's a good question.
See, the other question we had, and I'll get back to Dr. Bhatti had another question. The other question someone posted was from Dr. McFall. It was left main stenosis of 50 to 69% has a different outcome versus stenosis greater than 70%. Should we randomize PCI versus medical therapy in patients with unprotected moderate left main disease?
Oh, that's a great question. We're never going to do that trial. In the original, I think in the original CAS registry going back 30 years, there was a subset analysis that showed all the benefit of surgery was in those greater than 70%. And I do know of a paper that is currently in press that's going to show that people with left main disease of less than 50% have an adverse outcome. And what it may be is that left main disease, even if it's less than 50%, may be a marker of more extensive coronary disease, which may or may not respond to revascularization. But I just don't think we'll ever do that trial. I really don't. And I think now it's reasonable to say that it's a good question. It'd be nice to answer it. But I think we have to use FFR and other modalities to determine whether it's a significant lesion and responsible for symptoms and or ischemia.
Thank you. I'll try to squeeze a couple more questions in here. Dr. Hunley asked, said, thank you for your excellent talk. Could you speculate for us on your thoughts about the future role of cardiac CTA, coronary CTA, to identify coronary artery disease and direct therapy?
I think it's changed. It's changing our practice. It has certainly changed mine. I really enjoyed being the American, if you allow me to use that term, on the ESC writing committee. I've been on 2 or 3 of them, and my role was kind of to try and make sure that the guidelines were reasonably similar on both sides of the pond. And I was struck by a lot of the discussion that really made the case for CTA. And I became a convert. And really what we said, there's a very good diagram in the European guidelines. Basically what it says is, if you have a low to intermediate likelihood of coronary disease, CTA is a very good screening tool because of its very high negative predictive value. And the fact that, in the Ischemia trial, 14% of patients who would have been enrolled based on a stress test had non-obstructive disease, and 5% had left main disease. We then said, if you've got a high likelihood of obstructive coronary disease, and you're considering angiography, then you don't want to do a CTA, because CTA really is not good at identifying the specific characteristics of a lesion. Its strength is mainly its negative predictive value. So if I have someone who I think really does have symptomatic coronary disease, and I'm considering revascularization, I would go to a stress test to try and document what the patient can do. I mean, if they go and have a functional aerobic capacity of 100%, and well, maybe you can keep them on medical therapy. But there, I think a stress test plays an important role, not for diagnosis, but for identifying functional capacity and limitation. But I don't want to do a CTA and then have to do another angiogram because the patient is going for PCI. So I really tend to favor CTA. We put it right up in the diagnostic armamentarium. For low to intermediate likelihood, it's a fantastic screening tool. And then when you add FFR to it, which is going to happen, I think it'll be an even stronger, a stronger tool.
All right, thank you, Dr. Gersh. I know we have a couple more questions in the chat, and a couple people have texted me directly asking questions, but those will, you know, if it's okay with Dr. Gersh, we may just push those to email later. And then we, of course, look forward to speaking with Dr. Gersh at noon. We're going to meet with the fellows and have a chance to chat a little bit more with you. So we're all looking forward to that. But thank you, everyone, for joining. And then don't forget, there's the CME credit there listed. Just text the 804 number and then the code is shown. But thank you again, Dr. Gersh, for a wonderful lecture.
I'm happy to answer them on email or whenever.
Thank you so much for your time.
Thanks so much, Bernie. It was absolutely fantastic talk.
Oh, thank you, Greg.